If not, we'll go into the next talk, that is by Dr. Krishna Prasad. He's a very familiar figure in KSOS. Dr. Krishna Prasad has been here with us for so many conferences. Today he'll speak on changing narratives for scaling up your cataract practice.
Good morning. Thank you KSOS for having me here. See, our belief systems and our mindset actually decides the narratives that we keep believing, keep telling people. And that is also true for our practice, especially the cataract practice. I've been thinking for the last few years, like how the way we think, the way we believe, and the things that we have fed over years actually change the way we actually practice and we talk to our patients. See, I'll restrict this to talk to a phacoemulsification surgery, which is the main bread and butter and probably the very sole purpose of our existence. We have evolved in the last 30 years. I still remember when I joined RP Center 30 years ago in 1992. Like there was one mission, Dr. Mahipal was here, was the only solo phaco surgeon that he was doing, and we saw from there it was a 3.4 millimeter scleral tunnel incision, and there was only one lens available from Star to put there. So from there, and it was under a peribulbar block. From there, our techniques we have perfected, and the technology also has come by, and there is a marriage of these two to create probably, and today I think most of us will agree, that we have come to a stage where we are really doing a very good job. Our patients are having a very rewarding experience. The whole cataract surgery experience of a topical phaco is really remarkable, that we have really reached some stage, and this probably evolution is still continuing, but at this point of time we can be really doing that. But what has changed in last 30 years is that the topical phaco, see this block surgery under a peribulbar block is a game changer. We always think both are okay, anyway we are doing it for the sake, we can give a block. But please understand, for the patient, it makes a big difference. If the patient can get a surgery under topical anesthesia versus a peribulbar block surgery, it's a hell and heaven difference for the patient. So topical phaco, since we are able to do under topical, that has been the biggest advantage of phaco over maybe SICS or ECCE. It's a quick surgery. Most of the surgeons, experienced surgeons, take around 4 to 5 minutes to complete the surgery. So this very short surgery is very important for patients who have systemic problems and stress-related problems. So quick surgery has been basically the advantage towards the patient, and the difference is the T-leaf studio. We just enter the clear cornea and we just finish off the surgery. We don't touch the iris. So there's a very minimal corneal damage, because we don't get the nucleus into the AC and take it out. We just break it up. At the same time, we don't touch the iris, and a shorter surgery. So we always have a very minimal inflammation. So which actually we don't have to use too much of post-operative steroids. And what has changed is the biometry. That is, everybody agrees that the latest optical biometers with all the formulae that we are able to have a bang on the post-op result that we want. And we have understood how to work in very extremes of axial lens. And this evolving science that we are keeping abreast with has really made the surgery very predictive, so that we can really experiment and build on this. And we have this PC IOL today is not posterior chamber IOL. This is for the postgrad. This is presbyopia correcting IOL. The present stock of presbyopia correcting IOLs that we have has been an excellent thing that has happened. We have a lot of lenses with better light transmission. And also the Indian economy has changed. Now the people are ready to pay out of pocket, out of insurances. Now there is a health spending on the eye. It is no more something which can be related to the overall mass surgeries in the camp with a low cost, quality surgery. It is where people can spend for the most important part of their life, that is the quality of vision. And what has not changed is our attitude. I think we still are under the hangover of taking cataract surgery as a sight restoring surgery, where a person comes as blind and we do the surgery or whatever technique and patient starts seeing. It is something that we commit a lot of mistakes in our narratives. One thing is, it's only for an opaque lens. We always do a condescending comment, on somebody who is doing a surgery on a clear lens. Clear lens extraction is a very condescending word, like California cataracts, or people who do for basically money's sake. Even though there is no cataract, you just do a cataract surgery. No. Basically, you understand the lens becomes dysfunctional after some time. The very fact that the patient develops presbyopia by 40 to 45, itself the lens is not able to deform the way we want. So the presbyopia is the leading thing now. This is going to drive our decision making in future. With all the availability of gadgets, the need for near vision for all illiterate or literate alike. So this is going to be the driver. So it need not. Once the lens stop deforming and creates a presbyopia problem, it is dysfunctional. There are changes in the lens, aberrations get added, the internal aberrations, the quality of vision comes down, there is a photic phenomena. The patient may be 6'6" on the Sneller's chart. We don't use a Pellier option in our OPD, so obviously we are not aware of what the lens has done to the patient's quality of vision. So it is time to now move that we need to work on the dysfunctional lens. And since we are able to do a very good surgery, a very safe surgery, very quick surgery, and that too it is much easier on a clear lens with a better zonules and better capsule behavior, this is something that we need to say. And we are okay that the patient wear glasses. The spectacle independence has been always linked to the elite, has been linked to the rich. No, every patient, if they are able to see far and near and intermediate without glasses, it is a great quality of life enhancer. So this is where we have to work on presbyopia correcting IOLs and the toric counterparts, where we need to make the patient emmetrope and spectacle independent. So this is something that we need to work on. And this is another thing which I've been working for last few years. We always tell the patient there's an asymmetrical cataract. We say get the right eye done, left eye at your convenience you come. We really do not say that both eyes have cataract. There's a binocular vision. Your patient has to work with both eyes. So you cannot operate one knee replacement and do the other knee replacement after 2 years. Patient will still be limping. So for the sake of binocular vision, if you say the 2 eyes have to be done with minimum gap, maybe the time for immediate sequential surgery is also in future. So just change the narrative, it will make a big difference. And we are not really making an attempt to dispel the fear or the public myth that is associated cataract. And also we don't really blow a trumpet about the topical phaco. There are a lot of people who can do SICS and claim it to be as equivalent. No, we need to make it very clear in our narrative that topical phaco is the way that anybody should undergo surgery, and obviously other surgeries with a peribulbar block, a scleral tunnel, nucleus coming into the AC, lot of iris and cornea damage potential has to be analyzed, and that is something very important. I think I had doctors in my place who came with presbyopia. They were not happy with their glasses, and they had clear lenses, of course. Some of them were into fitness. They could not wear glasses and run marathons. So this is the time it started that I operated many of the doctor colleagues of mine, and we, with the present day available presbyopia correcting lenses, what we call as Prilex, it has changed their life. I have personal accounts of all these doctors, and they say that this was their best event that happened. Because anyway, they're going to get cataract after 10, 15, 20 years. You just prepone them in their prime of life, they can be spectacle independent. And geriatric patients, that is what we get majority of them. They need more push because they're already socially underprivileged. There's already some caretakers who wants to finish the job with paying lesser package or lesser money. And these old people don't spend money. They always have that austerity or money saving mode in their entire life. Even though they have lots of money in their bank account, they never spend it for eye care. So that is where you need to actually talk to them, and they actually need more push. Because they always want to go with the lowest package, because they think, why anyway, we have got only few years to live. They don't really, even though they have money, they don't spend. I think this is where we need to actually turn it around. And my present narrative is presbyopia is the new menace, and we are not doing enough. If you are a presbyope, you will understand that it is something to see clearly without glasses for near is a great feeling. And the cataract surgery will take care of this with the present lenses. Why do it at 65? Why not at 55? If we can prepone it, why not? And these patients who are really suffering from poor quality of life because of their dependence on glasses, it is something that we need to really look into. Of course, the science of it is something totally a different talk. And advise surgery for both eyes. Binocularity, trying to bring them both eyes, I mean surgery without much gap in between, to avoid all the problems of neglected cataract, giving rise to phacomorphic glaucomas and things like that, or the loss of stereopsis because of the cataract in one eye need to be taken care. And they are not doing a favor by getting surgery by you. You think that you are actually doing a favor by changing their life, by giving them the greatest gift of life, that is the sight to all of them. So thank you very much for your patient hearing.
Thank you, Dr. KP. Actually, it is more of communication skill development. I absolutely agree. I was just remembering one case, a combined case we had last week. Patient opted for the highest premium sum length. There was a PC problem, and we had to put that lesser lens. And I did vitrectomy, everything. Then I went and told the patient, there is backside I am doing some procedure. So the lens you chose was little rigid. So I made another one. No problem, sir, doctor, no problem. So
actually,
they agreed.
And
they are, how much I have to pay more? They
exactly.
Said, then I said, no, that is not more. Actually, it is little less. Don't worry about that. Very happy. Otherwise, if the account people tell 45,000 was not put, only 20,000 was put, they will think that we have given a lower quality.
A compromise.
So they were very happy. So this sort of communication, absolutely, I agree with you. You are a master.
No, at the same time, the geriatric population, what I say is simply I just emotionally blackmail them. I said, how many kids you have? There are 4, all of them America, Australia, they are vice presidents. I say, you have done so much for your kids, for your family. What have you done for yourself? This is the time, you have money, right? I know you are well placed. See, this is the time you spend for yourself. It is found, I have known that with personal experience, a lot of old people leave a lot of money in the bank account and they don't spend it on themselves. And we are doing a favor by actually doing it. It's not a commerce. I'm saying it's a question of morality. The person should be taught to spend for himself, for a better vision.
Absolutely.
See, why wear glasses, have a bifocal and trip on the stairs when he can have a presbyopia correcting eyeball and move around?
Another thing is we keep postponing. We will ask the patient, how are you? Okay, everything fine. Then come next year. Then they keep on aging. After 4 or 5 years, when they come for surgery, they will be very
yeah, they always come with advanced cataract. See, that is the thing. We postponing I just change the narrative. I say the both eyes have to be done without much gap. That is the only thing. I am not very coercive. I don't really push too hard. I just tell my sentence that both eyes have to be done. Because some patient asked me, sir, can you do both eyes at the same time?
Yeah.
That was the eye opener for me. Thank
Absolutely.
you.
Thank you. Thank you, Dr. KP. I request Dr. Sirisha Kumar for giving the talk on phakic IOL. Any communication skill development, anybody can directly contact Dr. Krishna Prasad. Anybody in the audience. No questions.